at from 6 to about 16 calls a day, no matter the season, and I freaking hated it. I was like, this is bull crap. I just want to sit down and relax.
I got a couple calls before I got there, and then they got called to a structure fire. RP saw a 15-foot flame, and they couldn't find the fire.
Yeah.
I don't know if it was a chimney fire that self-resolved before anyone got there or what, but the RP was.
Probably someone goofing off with the flamethrower that they bought. Those have been circulating the valley lately. Boyce bought one.
I want a flamethrower. Tell me where boys hook me up.
Gun show, man. That's where you can find them.
Am I old enough to go into one of those?
Yeah.
Oh.
I don't think they're restricted.
No, they're not.
age-wise.
They're not restricted.
Can I get a bedazzled gun?
Yeah. You're over 18, you can buy a gun.
And I have no felonies.
Yeah.
Yeah, that helps, dude. You can buy one if you got a felony. You just gotta, go with different juveniles.
Yeah.
There's a few extra steps, but still, like, I want to make sure it's all above board. I want my bedazzled handgun. And I can conceal and carry this, and it's just sparkly.
Last time I went to a gun show, I saw some young adult and her older mother that obviously had no idea about anything about a gun, looking at pistol grips with like no barrel attached, no nothing, just the grip and the plastic casing that goes under the barrel. And the mom's like, hey, that's nice and lightweight. She's like, you should get that one. And I'm just like standing there watching them, just like,
Yeah, actually, you know what? They should probably get that one.
That's probably the one they need.
And the guy selling them is just like looking at them so bewildered. He's like, are you really like this? Like, really?
You should get two of them. Super light, dual wheelbase, no recoil. It's really easy to use them both of the same
Super
time.
quiet, yeah.
They double as throwing stars too.
No, that's all they do. They don't double for anything. That's the one they do.
They shoot air if you blow through it.
Maybe you can put a spitball in it.
Yeah. Gosh. I do feel bad for some people. Like, I started laughing at one point because I couldn't help myself, and the mom glared at me. I was just like,
Just tell her get better at guns.
I can't.
You live in Montana. Look, I understand that you
But you do live in Montana.
Yeah.
During COVID and all the libtards of California decided they suddenly need guns, You're going to these gun shops and like don't know how to hold these things. Like if you never even like played with a Nerf gun, like barrel goes that way, the not barrel goes this way.
Front toward enemy.
down the bowl.
I love those trailer hitch guards. Those are awesome.
What are they?
It's a freaking like landmine replica. Yeah. This front toward enemy.
I want to say that too.
Yeah, I love it. The first time I saw one driving around here, I was like, oh, it's like, I want a truck just to have that now.
If you've seen some of the dudes in the army, you'd want it to say front toward enemy too.
Yeah.
Super simple.
Arrow. This side toward enemy.
Which I will give them this. A claymore is not as obviously sighted as like a bullet. You know,
No, but
where
it's
it
like-
only goes in one way. It's like
No.
I gotta be creative with those
But it is a
ones.
direction line.
it is, but it's not
You
like
kill yourself by eliminating the middleman and
It's
just
like-
putting a
Yeah.
bullet on a table and then
Yeah.
slamming your forehead into it. Would that do anything?
You
Besides,
need a lot of freaking force for
well, I mean, you
that.
think just
The bricks of
Wham. Flat wooden table.
One way to find out.
Try it. Science is all about experimentation.
Yeah.
If you burn
Take
it-
one. I hypothesize that I might die.
What? Warmer.
Oh,
I couldn't breathe.
wow.
I had to sit there and think about it. I was like, it was like 7 o'clock, it was -5, and now it's -4. It's like, it's not, I had to remind myself it's not getting colder, it's getting warmer when it gets lower.
For the negatives.
He's flying out at sea, and so they would fly along the front of ships on the carrier decks. They would fly big boxes of food over, and the food said not for human consumption,
Yeah.
but for prison and military use.
Good morning.
You good?
Yeah, I'm reeling. Having a day.
Dog food, basically.
I can't wait to do I am. Is it safe to use somebody at the fridge for pissing giggles? To make their heart go really fast, but it didn't have any breathing. It's like
You can do it anytime.
draw
But like, yeah.
1,000.
Yeah, that's right.
Up to 1,000 epi, intramuscularly.
And then the exams, then we'll do that.
Okay.
Yeah, it's not.
Tasted like caramel.
So, but wasn't there one
Wait,
site for
wait.
the 19, didn't it say quiz?
Yeah, because what I'd like for everybody to do is to have those done. By the 19th. So
Okay,
that way I'm keeping everybody, if I don't put a deadline, then no one does it.
right, okay.
Just to get everybody, but it took us a while to get platinum working with that, so I may end up having to extend that date a little
But
bit.
it's not available on there right now, is it? Because I didn't see a
The
quiz.
quizzes?
Yeah, are
They
they?
should be. You guys did the quizzes.
Yeah, I did some of the quizzes
I
last
get
night.
the emails about the quizzes, so I've got to go in and check, but I saw that.
Yeah, so I
I
was,
mean, all the assessments and stuff were, is
Yeah.
that what you're talking about?
yeah, the assessments, and then now the quizzes are actually up and running for the
It'll
chapter.
be just below the assessments.
Okay, they're on there right now?
Yeah.
They're on there now.
But they weren't a few days ago, right?
Yeah.
Okay.
Right, it just happened this week.
Okay.
Yeah. And so I was gonna announce that with everybody is, hey, we got a little bit behind with that stuff being active and up and running. And then I still have some people that still haven't even signed up for platinum. So I sent out an email to everybody that hasn't registered to say, hey, we gotta get everybody up on platinum.
Does that quiz say like what chapters it's through?
Yeah, it should say what, 'cause
It'll say week 1, week 2. So I had to check the calendar to make sure I was doing it right.
you can open book, so you can go through your,
Right, okay.
you go through your material and look at it.
Cool.
And the other big thing is, with the quizzes, they're not look at it from the content standpoint. We're trying to prep you for National Registry.
Right,
So you might try to go find that information in your book and go, it's not specifically written there. Well, that's because I'm not trying to help you pass the quizzes for this textbook. Because what we're finding is that National Registry has changed so much
right.
that students were doing well on the textbook, going to take the National Registry and then not doing fine. So that's why we're using that platform to say, hey, understand this information. You should be able to find it in your text somewhere,
Right.
but it's probably not going to be written word for word, but this is what National Registry is expecting you to know.
Grasp the concepts and apply them.
Yeah, apply them across the board, so, because they're looking at all the textbooks in the country of possible content that they are gonna test you on. I'll repeat all that here.
But like on the open book quiz, you could use the internet stuff too then, right? I mean,
Yeah, absolutely,
so I mean, that would be like you're saying, you can't find it in the textbook,
Yeah.
just do a Google
but,
search.
okay, we're at 10:02. Okay, welcome everyone. Can all of you on Zoom hear me? Okay?
Yeah.
Good. Thank you. Amanda's also online, so she's gonna be following the chat. So if you guys do have questions, you can put that in the chat box, and then if you do
Yep,
want to.
I'm here.
So I wanted to go over a couple of housekeeping things. For those of you that are watching this right now, there's a few of you that still have not registered and signed up for Platinum. Let's see the chat quick.
Oh, no.
And so I really need for you to get signed up with Platinum, because we've got the quizzes up there. I need you guys to start doing the assessment. If you haven't done the assessment, please do the assessment. it's not towards a grade, it's just to get a general idea where you're at, where your strengths and where your weaknesses are. It helps us understand where you are as a student, because we have a variety of different backgrounds, education level, age, demographics that can all play into where you, and if you are struggling, it helps me identify those weaknesses too, so that we can work together to help you get through this program. The quizzes are up. I'm gonna tell everyone, be very careful not to take and copy and paste any question from the Platinum website. If you directly copy and paste that onto Google to do a search, it's gonna flag me, it'll flag you, it'll suspend you for 3 minutes, because they don't want that content shared online. Because it's about integrity of their testing process, and it's their proprietary software that they're protecting. It's also to protect you, because you'll know that the tests aren't available to the general public, and you have people that are using different sites that that are basically cheating and taking the test. If it happens more than once, then you can get suspended from using your Platinum account for like 1 or 2 days. And then if our program has a lot of students violating that policy, then we could be banned for life and never be able to use this platform again. So it's very important not to cut and paste or share that information online, because they have these spider bots in the techno world that are constantly combing the internet. Every morning they get a report of where their content has been found. They can trace it back to who the student was, the email address, the time it was shared on a website or shared on Google, and they're just trying everything they can do to protect that information. If we lose access from it, would be detrimental to our program. Well, the problem is, if you lose access to Platinum, then you're not going to be able to test prep and get ready for the National Registry. So yeah, it would be really hard for us to be able to give you the closest to the National Registry, but not having access. If you're sharing it unintentionally, everybody gets a hey, don't do that. But if you continue to use it, then it makes it hard for us to keep you here as a student. Especially if you're trying to if you're outright blatantly sharing it with a platform that is known for posting content for cheating, then yeah, you would not be able to continue in this program. So we take it very seriously. They take it extremely seriously, and we don't want to jeopardize our whole program and all of our students by not being able to utilize the platform. So if you're going through one of the quizzes, you can't find the content in your textbook, please keep in mind that the Platinum testing platform is looking at all the different content that's out there, all the different authors and out there. So you might say, well, I didn't actually see this test question or this answer in my textbook. You're not going to find that. But you will find the general content, hopefully. And if not, if that's missed out of this particular textbook, it could be that it's in another textbook, or you could try to search for that general information on the internet if you need to find that answer. But like I said, do not directly cut and paste to find that content. Our goal is not to get you successful in passing the quizzes for this textbook, because the National Registry changed back in July timeframe, and the goal is Platinum's there to help you prepare for the National Registry, because all of you are here to take National Registry for the most part. And if we just do just the quizzes from the textbook, then you're going to have a false sense of, well, then I'm going to do well on the National Registry, and then you may not be as successful in completing the National Registry exam. That's why we set this up. We're trying to see if this is going to help with first-time pass rates, because none of you want to pay $100 and some to National Registry to take it multiple times. You're paying good money to be here. We're trying to not only give you educational content and help you with understanding the material, but we're also trying to prep you so that you can pass the National Registry because that's what we all want to do, and we don't want to have to take it multiple times. Okay, any other questions regards to platinum? So the assessments there, please do the assessment. The quizzes are up, so please do those. And then we'll do an exam. I think it's on the 29th. I don't have my calendar right in front of me. Just depending on where everybody is as far as the quizzes, I may end up pushing that exam, that first exam out a little bit, just to give people more time to complete the quizzes, because we didn't get that launched right at the beginning of the program when we first started. So there'll be a little bit of flexibility with that.
So since the quizzes and the tests were posted late, are they still expected for them to all be due the 19th, or are we pushing that out a bit too?
I'm gonna push that out because I just have a lot of people that still haven't even signed up to platinum.
Perfect. Yeah, we were wondering because with shift and everything, we're also just been running behind, and you want all the assignments, so like the test anxiety, the math, all that stuff done as well, correct?
Correct.
And Kyle, how do the exams work? Is that also kind of flexible, or is that like a set day that you have to be?
I want it to try to be done within that week.
Okay.
Because if I don't put some sort of a deadline, then nobody's gonna do it, unfortunately. So I'll extend that out. I'll probably extend that out another week or two. I just need to look and talk with Amanda a little bit and just figure out where everybody is. I wanted to see where everybody was at today, as far as how many people have actually done the quizzes, and then try to just get an idea of how many other people are still left. I think there's still 4 or 5 people that still have not even signed up for platinum. So I don't want to have that many students not even registered, and we're not all moving together through that process. So I suspect I'll push it out probably 2 weeks, but I'm just gonna look and see where everybody's at. So if you can do your best to try to get signed up, if you're not, take that assessment and then start working on those quizzes, that's to your benefit.
And the exam is not open book, correct?
Correct.
Okay, cool.
But you'll just need to take it, you know, in good faith that you're doing this. Now, I mean, I'm not gonna be watching over your shoulder, but the reason we're putting those exams there is so that if you go take that content for National Registry, wouldn't you wanna know, hey, this is where I'm doing well, and this is where I need to work on. That's why we're setting this up. I look at quizzes and exams not as punishment, or you're really smart or you're really dumb, but rather, where's my strengths and where's my weaknesses? So that if I have weaknesses, I can know where to study that content and be able to do better on it. Because at the end of this program, we want to go take National Registry and pass it the first time. So if you choose to use your book, I can't stop you, because this is online, this is hybrid. But just look at it as an opportunity for you to take that exam to really understand whether you're understanding the material, or just how the test is laid out in the methodology of test taking for National Registry. Okay. Any other questions about that? Okay, so we're going to talk about our approach to patient assessment and critical thinking when we're going into an environment and we're going to talk to our patient. What are some of the things that we need to do when we're looking at scene size up, primary assessment, secondary assessment, and then reassessment? This is becoming more important now as an AEMT, because you have all been, you know, EMTs for a little while, had some patient contact, you understand the flow, and if you have a good paramedic partner or another good EMT partner, you can see how they've learned to adapt their questioning, how they communicate with patients, to be able to gather the information that we need in order to make a decision about what type of treatment and care we need for this patient. How do we package them up in a timely manner and then transport them safely to the hospital, and then turn that patient over to whoever the care provider is, whether that's another paramedic, whether that's the RN at the bedside or the physician. It is a way for us to make sure that we're seamlessly transferring care and doing our best to take care of everything, and not missing things, and not missing basic things. So some of this may be just see a little bit redundant, but it is very important that we really hone in our assessment skills. So I like to take a systematic approach when I'm talking to my patients. Starting with, when we think of patient assessment, when we get on scene, what are the first things that we're thinking about?
Scene safety.
Scene safety, obviously.
Nature of the scene, like you need more resources.
Sure. Body substance isolation, PPE that we have that's gonna protect us. So having that mindset at the beginning lays that foundation for success throughout the call. Okay, so if we're in a unique situation such as a tanker and an MBA, what would be some of the things that we would consider if we were looking at this scene?
What are they carrying in the tank?
Okay,
Is it breached?
yeah, is it leaking? Is it leaking?
Leakage, blockage.
Traffic control.
What resources would we need for an incident like this?
Fire department.
Law enforcement.
Okay, so we'd want to traffic control, right? Hazmat, if we do have a leak or a breach in the container that we're using. Let's think about how many patients could we have with this? So how many could be in that, the 18-wheeler?
Oh, 1,
Two,
2.
potentially.
Yeah, you never know, okay. What about it looks like we've got a small sedan and then possibly an SUV over here. So we could potentially, this could be a mass casualty incident if all those vehicles have people that are in that are injured. Then how would we know what this material is? How would we determine that?
Placard on the back.
Okay, placard. What does the driver carry?
Chart.
Bill of lading or-
Yeah, should have the manifest should be in the driver's side door so that we can determine what chemicals are on board. What if the driver was incapacitated and we couldn't get to that manifest? What book do we carry in our? Okay, the response, yeah, so then we can open it up, we can see what it is, and then give us a basic rundown of, hey, this is what we need to do to secure this scene. Identifying what is our hot zone or warm zone and cold zone. Okay, and then identifying how many patients we have, do we have the resources to be able to treat and transport those patients? Okay. So assessment is based on analyzing the surroundings, the situation that you're in, being able to have critical thinking in place to determine, is this scene safe? What is it that I need to do? And then find out, okay, start at the beginning with assessing our patients and getting our first general impressions. So at the scene, the patient's environment, mechanism of injury, how much damage is done to that vehicle, potential injuries that we could suspect, safety that we're gonna put in place to make sure that we are safe and we are minimizing that risk of our patients. Extrication time, how long is it gonna take to safely remove those patients if they are entrapped? And provide that care. So if I have a patient that's entrapped and needs extrication has not arrived, or they're setting up extrication, or I've been on extrications that take an hour or an hour and a half because of the complexity of how involved that patient is. How do we treat and assess that patient that's not on a cot? Okay, we have to get inside the vehicle. Maybe we've got to make some adjustments and be able to start doing our primary assessment, start treating. I've started IVs in the back of cars, given pain meds because now we're gonna finally move that patient. They've got a broken femur. We wanna make them comfortable. We wanna stabilize them and not just leave them to the environment and we gotta wait till they get cut out. No, that's not what we're gonna do. We're gonna initiate that patient care as soon as possible. Okay, so these are the questions you need to ask. Safe approach to the patient, nature of the problem, stable, are they stable, unstable? So when I think of, is somebody stable or not stable, what are some of the things that go through your mind? Okay, can they walk?
ABCs.
ABCs, yeah. Well, what's another one? Mentation, AVPU, GCS. That's gonna give me an indication. How many of you are really good at memorizing GCS scale? Okay, be honest. Okay, how many of you just get a 13 or a 15? Right? I don't remember it, especially when there's a lot going on. But what I do is I have a GCS, I had it on my clipboard, so that when I looked at GCS, I wasn't making up the numbers, but it is really important. It's not so much important when we have somebody that is stable. Like I could say a 13 or 15, is that really gonna make a difference? No, but if I have a critical patient, I really want to give an accurate GCS and have a baseline when I come on scene so that I can see the interventions that we're doing or how the patient's condition is changing. Is it getting better? Is it staying the same? More importantly, is it declining and getting worse? So you see, it's really important. You need to think about GCS is set up for a reason. It's to give us a baseline to start with and to see if the outcomes that we're doing are going to be positive or negative or neutral. And that's helpful for the hospital. Because even if that patient is declining, we're recognizing it and we're trying to intervene. And they may still continue to decline, but we at least know where they started and where they're going to end when we transfer that care over. So it is more important than just kind of making up that number. So I would strongly encourage all of you, have that GCS so that you have access, whether it's a card you carry, whether it's an app you pull up on your phone, whether it's on a clipboard. That way you're getting a more, because we really want to determine sick or not so sick. And we want to determine that quickly so we can make decisions to stabilize somebody. Okay, resources, ask for those resources if you think you're going to need it. Better to take away than it is to realize, oh, we should have added 2 ambulances instead of 1. We should have called alert 10 minutes ago. Maybe we should have pre-dispatched alert because of the amount of calls that we're getting into 911 that are saying this is a much bigger problem or bigger incident. Okay. And then deciding how are we going to transport that patient? What is our ETA to the hospital or the closest facility? Is the incident large enough that it's probably going to oversaturate the clinic or the hospital that we're working with? So then we got to think about sending those patients even further out. Okay, so when you do a systematic approach, you minimize that chance that you're going to overlook things. You become more efficient in your assessment and allocating those resources. How many of you have been on a call where it's just you and your partner? Yeah, plenty of times, especially here. That's a common practice. So wouldn't you want to be efficient with what you do have, even though you may not have all the resources you would ideally like? If you lived in a larger metropolitan area where you had fire trucks stacked on top of each other, but that's not always the case, okay, especially here. So it's even more important to be systematic, organized, and thorough in your assessment of the situation. Okay, so we're all familiar with this, the 4 essential assessment process of scene size up. We talked a little bit about those, identifying hazards, determining what resources we need. What's another thing that we also do with scene size up that most of us sometimes forget? T-spine, okay? Whether we need to put a collar, whether we need to fully immobilize somebody, we always got to keep that in mind. And then having those resources available. Then we go into our primary assessment. So we're going to talk more about this as we go through each of these modules. And our primary assessment is a quick assessment of identifying life threats, airway, breathing, circulation, and in some cases, circulation, airway, and breathing. Then our secondary assessment is just to make sure, hey, if we've got everything stabilized with our airway, breathing, and circulation, are we going to do a head-to-toe detailed physical exam? Okay. And then are we going to find any of those other things that are less concerning but still need to be addressed? Then we want to complete that secondary assessment, focus our exam on what is the problem or the issue. Also, don't forget your sample on your trauma patients and OPQRST. OPQRST and sample can still be very relevant, especially with trauma patients, because of the fact somebody has a trauma doesn't validate that they may also have underlying medical conditions that we need to address, ask questions, and identify. And then once we've done all that, and we still have time, we're not at the hospital, reassess. If we do an intervention or we provide a treatment, we need to be reassessing that. If we get a baseline of what somebody's oxygen concentration is on scene, right? We administer oxygen, or we continue to monitor to see the way that we're applying that oxygen, nasal cannula, non-rebreather, is that sufficient in maintaining somebody's oxygen concentration? If they start to deteriorate, a nasal cannula is probably not going to be helpful for somebody that then goes unconscious and unresponsive, right? So just doing an intervention also has to be measured post the intervention to ensure that that is actually providing that level of care. And then continuing with vital signs, communicating with your base hospital or the agency that you're going to transfer that care over, making sure that they understand what you've done, what you found, what you've done, and where are they at right now. Okay. Okay, so we talked a little bit about scene size up already. Identifying your hazards and crew doesn't mean that we just assume that everybody sees us in the apparatus that we're arriving on scene. You guys know about driving. We'll talk about that a little bit later on. Bystanders, patients are safe, minimizing that risk, accepting and benefit. Okay. If I'm not properly trained to handle that emergency, what resources do I need to get in place? If I don't have a well thought out plan of what I need to do, maybe we need to take a few minutes and decide, hey, is this risk worth what we're thinking of doing? Is that going to cause more harm? Or is that going to put us at a greater danger that now we're going to be part of the incident rather than the solution? Number of patients is important. How many patients do we think we have? We'll talk later about start triage or SALT, being able to properly go assess and determine the number of patients and how badly injured or how severe it is. Have you been on calls where it's like, oh, this could be a mass casualty, but everybody's walking around, there's maybe one person has a twisted ankle, and you're like, well, that was a big letdown. Thought we were gonna be doing some stuff, okay? And then other times you're surprised, you're like, well, there's a body, and there's a body, and oh my god, okay, it's dark, okay, well, let's look around the whole scene, because we may have multiple people that have been flung out or ejected. Mechanism entry, this is always important to be thinking about why we're there and what it is that we suspect is going on. Evaluating constantly through the call if we need those additional resources. Sometimes you just need a few minutes just to get your bearings on what's going on and then be able to say, okay, well, let's make a decision. Let's upgrade this assignment. Or rather than just piecemealing calling units randomly, okay? Let dispatch know. Good on-scene report is really important because other units that are now responding can start preparing what are they going to do. And then if you're the initial unit that's on scene, helping direct where that resource can be used most effectively. And then, of course, just your general impression of what your patient or the number of patients that you have, getting an idea. Are they sick or not so sick? Okay. So, level of responsiveness. So what are we going to check first? We've got somebody. APU. Okay, so what is APU?
Alert, painful, responsive.
Excellent. Okay, so we're going to assess our patients and determine where they're at. Okay. ABCs, airway, breathing, circulation, disability or neurological assessment, exposure. The environment here in Montana today. What's the temperature outside?
-2.
-2.
It was negative 24 coming over.
Okay, so if we got a patient that's involved in a motor vehicle accident, their little cocoon is now broken with glass, and now they're exposed to -24, -2. How long is that tissue that is exposed to that environment? How long is it going to take for it to freeze? Minutes. Okay, how long is it going to take for you to arrive on scene? Well, it depends. If in town, maybe 8 minutes, 4 minutes, 30 minutes. Okay, if there's a big snowstorm that comes through, an ice storm, and you have multiple accidents. And of course, our Montanans are, I don't need a jacket, I just wear a sweater because I'm going only from my insulated home to my insulated car and then my insulated car to the insulated grocery store. So I really don't need to have extra blanket and supplies to keep me warm should I get into a motor vehicle accident, because nobody sets off, I'm gonna go get in an accident this morning or in this evening. So keeping those things in mind with the environment and what that risk is. And then minimizing those risks and then getting those patients warm, because that's only gonna further add complexity to. Let's see. Yep, that's true. Amanda wrote, my husband gives me so much crap about having cold weather gear, blankets, sleeping bags, etc., all in all the vehicles. Correct. It only takes one time to put cold and you don't forget that. I have teenage daughters and they constantly are telling me, Dad, I'm just wearing leggings and a sweater and tennis shoes and there's a foot of snow. And I'm like, it's -3 and you're just going to the bus stop. Like, wear a jacket at least. Put something on your head. But that's just me being dad. Okay, airway, breathing, circulation. So how do we identify those threats?
Are they talking to you?
Are they talking? So then we know they have a patent airway, okay?
Are they perfusing?
Yeah, perfusing. So what's a good way that we can assess, just looking at somebody, whether somebody has good perfusion?
Skin color.
Pallor.
Yeah, mentation, all of those things are gonna give us good indications. Breathing, we can probably hear somebody that has asthma, right? When you walk in, the look in their eyes, how are they positioned? Are they in a tripod position? Are they face down? Are they laying up? Are they sitting up? What are they doing? Those are all good ways of helping us identify very quickly somebody's airway, breathing, and circulation. And we don't have any equipment actually put on them, right? We can start to see that. But what if they look okay? Then what is our equipment in assessing airway, breathing, and circulation? Stethoscope, listening. Do we listen to all of our lung sounds on all of our patients every single time? And why is that? Well, they don't sound like they have asthma. They're talking to me. Hey, I'm just as guilty. Okay? But you should be doing that exam because you want to listen. What if you start giving them fluids and now you're starting to hear that, okay? You're starting to hear that fluids start to build up in the lower lobes. If you didn't have a baseline to start with, how do you know that it's getting worse or whether that was there at the beginning already? Okay. What other equipment do we have to assess airway, breathing, and circulation? Pulse oximetry. Okay. Okay, just physically checking someone's pulse. Another piece of equipment we use. Okay, leads, so we can look at the heart rate. Okay, we can even do a 12 lead.
And title.
End tidal CO2, which is especially when we get into respiratory, we're going to talk about the importance of if you have a respiratory patient, all of them should be getting and utilizing that end tidal. And helping you to understand what those waveform means is now a next level of understanding that you're going to learn and understand and recognize as being very important as an AEMT. Because that's going to give you a more accurate indicator that your patient is in respiratory distress or going into respiratory distress long before that pulse oximetry is saying, hey, their SpO2 is dropping. What's another piece of equipment that we use in assessing?
Questions, use your bystanders for history taking.
Yep, you can do that. And then, getting a blood pressure, we got to use that. What else can we look at?
Chest rise and fall.
Yeah, counting. Okay, just listening, watching, getting those sets of vitals is really important to determine where is my patient right now at this moment, and are they stable or unstable? And then how do we intervene so that airway, breathing, and circulation becomes stable? Okay, and we may spend the entire rest of the call trying to just maintain airway, breathing, and circulation. And we may not actually get to secondary assessment or be as thorough. Okay, so here's the assessing circulation, the 5 Ps: pain, pulse, pallor, what is their skin color, paresthesia, and paralysis. Okay, so we can look at that. When we do our assessment, we can ask the patient, can you squeeze my hands? Can you push, pull? We don't necessarily always have to do that just for a stroke. But if we want to figure out what's going on, these are all ways that we can assess that circulation and determine whether there is a problem. Also, we need to think about, is this brand new? Is this their baseline? And if it's not their baseline, when was the last time it was normal? Okay, was that today? Was that a week ago? Okay, have they had a stroke and now this is the residual, this is how their norm is? Rather than calling a stroke on somebody who's had a stroke 2 years ago, but we got too wrapped up in, oh, they're weak on the right side, and, you know, we gotta take care of it. Okay. So level of responsiveness, AVPU, GCS, we already touched on that a little bit. So keeping that GCS scale, have that as a resource. Where can I assess that? And then the environment that the patient is. And is there behavior appropriate? We talked to, what was it, last week or the week before, where we had our age and demographics of maturity of infant all the way up to somebody that's 104. Are they acting appropriately? Are they answering my questions appropriately? Or is their wording slurred? Or are they giving me inappropriate answers, not necessarily being mean or sarcastic, but when I'm asking them questions that they should understand or know, and they're giving me gobbledygook, or a response to a question that doesn't make sense. Then we need to think about the mental status. How is that being affected? And trying to determine, is this new or is this something that's old? Okay, priority. That primary assessment should only take really about a minute, 2 minutes at the most. And we're determining from that moment what we need to do for intervention, if any, and where are we going to transport this patient if they are high priority? And what's our closest, most appropriate hospital to be able to stabilize them? Most of the time when we have a critical patient, they need us to recognize it, stabilize, but they need higher level of care and more interventions that are going to be offered at the hospital, not necessarily what we can do on scene. Okay. Somebody that needs to go to surgery needs a surgeon, doesn't need us to spend a half hour on scene trying to package them up. We need to minimize that time. So it's establishing immediate transport. If we've got somebody that's stable, the airway, breathing, circulation, can we take a little more time to set up the IV before we get in the ride? Sure. Can we spend more time talking and investigating what's going on, asking our sample and OPQRST, getting that 12 lead EKG just because we should probably get one? That's a little bit easier to stabilize in somebody's environment if that's appropriate, and not have this, okay, we got to go, we got to go. Okay, so that's what you've got to determine. Okay, general impressions, we already talked about critical patients. Okay. Non-critical patients, so there's no need as far as airway, breathing, and circulation that needs to be immediately addressed. That's how I determine stable, not so stable. Okay, and then once we recognize, are they altered or not altered, then that also is another way. They may be stable ABCs, but if they're mental altered, then we got to think about, is this something more serious, neurological, under the influence of any drugs or alcohol? Mental health is another one. So if we have somebody that has a mental health challenge, whatever that may be, we also need to recognize that. Is that making the environment safe or unsafe based on how they're acting? Are they acting appropriately? Any non-life-threatening medical conditions or injury, then we can take our time. Does everybody we come across need to go to the hospital? No. So maybe this started as an emergency, but now as we start talking to our patient, there's no immediate life threats. Does this patient want to continue our transport to the hospital, or would they rather do a refusal and go POV? Or maybe they just want to stay at home, or stay at their office. So those are where we now can downgrade. Okay, what do we need to do? This is not true emergency that we need to move quickly. Okay, secondary assessment. What does that involve?
Baseline set of vitals,
Okay, so we've got that. OPQRST,
sample.
sample. And go
That's when
through
you
this.
start doing more physical assessments, like in your
Sure.
trauma patients. You rule out extenuating bleeding, but now you're going through and figuring out what.
What about the nursing home patient, that is called for altered mental status?
They're gonna get
Yeah, blood glucose, okay? Somebody who's bedridden, what are we gonna also wanna evaluate? Even though it may not have to do with the
Bed
general.
sores.
Sore, pressure sores.
Pressure sores, do we notice abuse or neglect? Has their, if they're unable to control their bladder or bowel movements, are they sitting in that filth for an extended period of time that you're like, somebody should have at least addressed this? Are they not getting bathed or taken care of? Getting a report from, if you can't get it from the patient, who can we get that information from? Yeah, and looking at that patient and trying to determine what's going on. Just the way we ask questions with sample. Signs and symptoms, we can kind of generally pick up on our own, but allergies and medications. I like to look at it from the standpoint of, how many times have you looked and talked to a patient, asked them, did you take any medications? They go, no. Do you have any medical problems? No. Why is that? Because we don't want to admit that we have problems, right? Or we're already seeing a doctor, getting a medication, so we don't have that problem anymore. And that's a lot of times, and then you go to the hospital and give a report, and they ask them, maybe a little bit differently, and then they start rattling off all this stuff, and you're like, were we not in the same room together? Like, did I just, like, in my head? And then they look at you like, you didn't even do sample?
Right.
You should know better. So what are some of the ways that we can gather that information by just simply just saying a yes or no? What techniques have you guys used?
kind of running through some of the major medical emergencies that you would want to know about.
Okay.
So be like, do you have any, excuse me, do you have any medical conditions I should know about, like any past heart attack, stroke, diabetes, and just list several things. So it's like, oh yeah, well, I actually do have whatever, just kind of, obviously you can't list everything, but just trying to, some of the ones that are.
Yeah, to stimulate that
common.
conversation, not just being a yes or no answer.
Ask if they have med list.
Yeah, do you have a med list? What medications have you taken today? Would that be important? So if I am gonna give somebody a pain medication, for example, I wanna know, have you taken anything for this pain before we got here? Because what if they just took it 5 minutes before we got there, and they've taken a Vicodin that they had, that's been sitting in their drug, cabinet for 2 years because they had knee surgery, and they just took that. Wouldn't that be nice to know before I start giving them more pain meds on top of that, and then wonder why they're now unconscious, not breathing? I'm like, what happened here? Okay, it's happened. So I always ask, are you current with your medications? So define that list.
Are you compliant?
Are you compliant? Because how many people they're on several medications, maybe a fixed income, don't have those resources, and now, no, actually, I cut that one in half. Or I don't take it every day like the doctor says, I take it every other day so that I get twice as much. But that may not be a therapeutic level that they've now self-prescribed to help with the hypertension that they have. So we need to also just verify that information from that med list. And then another one is allergies. So when we ask people about allergies, how many think if there's something negative that happens to me, I must be allergic to it? Okay, so example is morphine. Well, I don't like morphine. I'm allergic to it because it makes me nauseous. Well, is that an allergic reaction or is that a side effect? So it's a side effect. So then I can go, oh, I can still give them morphine, but maybe now what I'll do is I'll give them some Zofran so that they won't feel as nauseous if I do decide to give them the morphine. So always clarify if they have an allergic reaction, is it a true allergic reaction or more or less a side effect of that medication? Okay, let's see, baseline vitals, changing that history, events leading up, last oral intake, All of those things are really important when we get, when we're looking at SAM. And then OPQRST. So can we go through OP, onset, propagation, radiation? Exactly. So how is that gonna be helpful in describing what's going on with our patient? Those are leading questions that we can use to really get a better understanding of what's going on with the patient. Okay? Conducting a physical exam. Okay? Head to toe. So it doesn't have to just be a trauma patient. These medical patients can have other ailments or diseases or injuries that we're just not aware of because they're not as obvious, but it's okay. Doesn't mean we gotta start stripping everybody down trauma naked. Probably gonna get some complaints about that. But we can do a physical exam, assess the abdomen, look and make sure that we don't have bed sores on the heels or on the buttocks or someplace else where there's a lot of pressure. Just taking an overall look at your patient, just determine there's not something else that's hiding that you would miss. Okay, level of responsiveness, obtaining chief complaint. Do patients have more than one complaint? Yeah, so trying to just determine what is the biggest threat to this patient, and then just go with that. Okay, but you can have more than one complaint. Try to minimize those. Patients for secondaries, for rapid physical exam, vitals, questioning the family, bystanders, trying to gather information. What are some other ways that we can gather medical history information if there's nobody around?
Look for paperwork or.
Okay,
medications.
Medical tag or bracelet.
Can we look for
Information.
wallets, identification bracelets or necklaces, cards that might be in a card, or maybe a phone, there's apps that are out there. Trying to just to get together, if we can't gather information about sample, other than, as far as medications, allergies, last oral intake, events, what do we put down for that information? The medication little box, what do we put?
Unknown.
Unknown, yeah, unknown. Unable to obtain. What if the patient refuses to talk to you? Patient refused to answer questions, unable to obtain, medications, allergies, all of those things. So that way, at least those boxes aren't left blank. And then the hospital and whoever you're turning care over also is aware that you were unsuccessful in being able to gather that information, and that, now you're turning that over to them to try to figure out. If they're a person that goes to the local hospital, they may be able to pull up that patient record and be able to get that information too. So that's also. Yay. Okay, assessment. So head to toe, identifying those life threats, obtaining a medical history if we're able to in that time, not forgetting sample, getting those baseline set of vitals as quickly as we can. And then if we need to, we can do that more detailed head to toe exam in the back of the ambulance to minimize our on-scene time. Okay, non-critical. Okay, so physical exam, isolated injury, vitals are stable. We can spend a little bit more time talking about the patient. Say, for example, a fractured ankle. Okay, still a traumatic injury. As long as they're not bleeding out, like they're going to be uncomfortable. So we can take a little bit of time on scene to stabilize that ankle, put a good splint on it, check our PMS, talk to our patient, maybe even start an IV, give them some pain meds on scene, so that we're trying to stabilize them with that ankle, we're causing them less harm or injury, and they're more comfortable. And, maybe we do take 15 minutes on scene to stabilize them, as opposed to somebody who is critical, then we're not gonna wanna waste our time taking as long to do and assess that patient. Okay, reassess, ongoing assessment. We're always reassessing. We're reassessing for a critical patient, how often? Every 5 minutes. Can all of you sit here and say that every critical patient, you've gotten the vital signs for every 5 minutes? No, that's almost impossible to do on your own, because there are so many things you're also doing and contending with that need your attention. But if we have a monitor, we could also switch that setting to get vitals every 5 minutes. That's helpful. And that's probably the only way you're really gonna get every 5 minutes, okay? Anytime we do an intervention, especially if we're given a medication, we need to have a recent set of vitals. And then post, 15 minutes or 10 minutes, however long it takes for that medication to get going, to reassess, are we seeing improvement, no change, or now they're deteriorating? If you're giving a medication and you're not reassessing whether that's working, then that could potentially be harmful to the patient because you may not be getting the desired effect. And we need to intervene. But if you just leave it blank, where you only have 2 sets of vitals, and it was 15 minutes after somebody had taken a pain med that you had given them and you didn't reassess it, that could be problematic later. Okay, so reassess. Non-critical every 15 minutes, but every chart, especially for your non-critical patients, how many sets of vitals should you have? At least 2. Okay, I have seen charts where there's 1. There's no excuse for that. You should be able to get a set of vitals within a reasonable amount of time on scene. And when you're turning that patient over, have a recent set of vitals to make sure there wasn't a change, okay? Critical thinking and problem solving. So this comes back to knowledge-based facts, principles that you've learned. Your assessment is based then on, you're getting some additional training here, but you're also going to reflect on past experience that you've had. Sometimes it's been painful learning experiences that we've had to endure because we neglected to get GCS correct, or we neglected to assess that airway quickly. So we're constantly looking at and reflecting on what have we done in the past? Is this a similar situation that we had a negative outcome, or we could have done better? That if I see this again, I'm going to do this differently because that should be better patient care. Also looking at when we guys have a big call or a call that's more complicated, talk about it, discuss it. Do mistakes happen on scene? Yeah, I mean, you can take apart any incident and I'm sure you can find something could have been improved on. And that's what we want to do and not focus on, oh, I'm terrible and I can't do anything. No, but look at what can I learn so that the next time I'm in this situation or we're in this situation, we can provide better care. And that's where that comes back to analyzing that data, thinking about it, how can we do a better job the next time, and learning how to solve those problems in the future. Experience, I will say, plays a big part. When you initially start out as an EMT, or now you're going as an AEMT, you're gaining that experience. And if we looked at it from the spectrum of 100% of knowledge, right? And we're going to ratio it with textbook knowledge, school, and with experience. If you've had no experience, most of your decisions are going to be based on your education, right? And over time, your experience is actually going to be more what you're going to start to rely on and less on the didactic learning that you had. So if you have a career of 20 years and lots of experience, you're going to be making those decisions based on calls you've been on and less with relying on the book knowledge that you learned. So when you have an organization, you're going to have people at different levels of brand new, more textbook knowledge. And then you're going to have people that have 20 years of experience. They're going to be relying more on experience. So rely on those individuals and work together. So you're right out of school, you're fresh on those skills. Maybe they're not as fresh on some of those skills because they don't do it as much. So be there to help them. Making decisions where that patient doesn't fall into that nice clean algorithm of we'll do this or we'll do this. And that's where experience comes in and says, hey, we should do this one because this is actually best for the patient. So I'll give you an example. I had a kid that was riding a skateboard. It was a Saturday, so it's a minor. 2 minors, they're at the school. They jumped a chain that was blocking off the parking lot, tripped, fell, hit his head. So he's a little bit dazed, but he's alert, he's oriented, he knows where he's at, he knows his name, trying to get a hold of mom, called mom. And So we know he hit his head, but he's still, you know, that kind of somewhat of a concussion, kind of a little bit slower on things. So we get mom on scene. The friend has just said, yeah, he fell off the skateboard trying to jump over the chain that was there and hit the back of his head on asphalt. Okay, so it's a head injury, it's a minor. I can tell there's a little bit of a concussion that's taken place. Mom gets there, she's like, I really don't want to send him to the hospital. We're 45 minutes from a trauma center. So what do? I could make him a level 1 trauma because we don't know how long he was unconscious for, because his friend said, yeah, he was kind of out for a little bit. Well, how long? Well, I don't know, but I had to wake him up. So I have positive LOC on a hard surface, a minor. Do you see where, okay, I probably could do a high risk refusal, and mom is real insistent about taking him to see the doctor on Monday. Or do I make this a level 1 trauma because of the positive LOC and we're not really sure what's going on with this kid? He's got a concussion. So for you, what would you guys do? A or B? Trauma or send him home, high risk refusal? How many for, let's make him a level 1 trauma? Okay, so it's kind of a mix. Okay.
It's kind of, I mean, you can only do so much to convince
Right.
mom. But I would encourage
Yeah.
you, but if you
Could you
can't,
justify both though in your paperwork? So this is where experience comes in to help you make the best decision. Okay? So I talked to my captain who'd been a medic for 24 years. He says, I've been in this similar situation and it ended up, the kid had a head bleed. And based on this, in the best interest, since we don't have the ability to look and see if there is a skull fracture of some kind, we should send him to a trauma center. Mom was like, oh, you know, and you think about how much does it cost to make someone a level 1 trauma, send him in a helicopter, because we're not going to go by ground. That's a big expense. But if he ends up with a head bleed, dies, like that pales in comparison. And it's a kid, you know? So I told mom this situation. I said, if it was me and we're all here, like we would rather he get checked out and he's fine, then he ends up with a head bleed, he dies at home. So we decided to make him a level 1 trauma by mechanism, flew him to the pediatric trauma center, got a call about an hour later from the flight crew. Hey, that patient that we picked up, we just wanted to let you know that that kid had a basal skull fracture. He's going to ICU for observation. So is that the right call?
Yeah.
Do you see how experience sometimes will help you when it's gray and you could go this way or you could go that way? Now, nothing ended up negatively happening to that patient other than he had a basal skull fracture. It was healed and he didn't have any CSF fluid leaking. He didn't have any other complications. Was able to go home a couple days later. But could it have easily been a small bleed and then he dies during the night? Like I wouldn't want that on my conscience. So if you're in that situation, rely on that experience, but also then decide what's best for the patient. And we really have very limited tools when it comes to something like that, making the best decision. So that's where that critical problem solving comes into play. And that's what you are now. You're gaining that experience, but you still may not have as much experience, right? Okay. And it's all a learning process. So now I pass that information on to you so that maybe that will help you make a better decision. Okay, let's see, questions guiding patients, approach, problem to patient, okay, we covered a lot of that stuff, okay. Formal structure. Yeah, I think we kind of covered a lot of that. I don't want to go over the redundancy of it too. Pattern recognition, problem solving, things you'll recognize. In the field, you'll see similar things that a patient's going to present with that are going to help you differentiate this person's sick or not so sick. Recognizing those patterns of symptoms that you're going to see. So chest pain, what would be some of the patterns that we'd look for if we were determining, is this respiratory or is this cardiac? So if it was cardiac, what would be some of the things that you would recognize? Okay, jaw pain, radiating to the shoulder, okay, nausea,
More of a
What?
consistency, less of just when it's.
pressure, feels like an elephant sitting on my chest. Well, how many elephants have you had sit on your chest? But how many times do you hear that saying? It feels like your chest is being crushed. As opposed to somebody, if it's more respiratory, well, when I take a deep breath in, that's when it's a real sharp pain. Okay? But it's not constant, as opposed to cardiac, it may be constant pain, pressure, radiates to my jaw or my neck. So you're gonna see those patterns and you're gonna go, I think it's more cardiac. So let's focus on the cardiac algorithm than opposed to, I think it's respiratory, and maybe it's a pulmonary embolism. Maybe there's a pleural effusion and it's rubbing up against, maybe they've had pneumonia. So that's where those things that you're gonna go, looks like a heart attack, smells like a heart attack, walks like a, probably a heart attack. Could be wrong, could be something different, could be nerve pain, could be a dislocated rib that can also simulate some of those things, but you're gonna see this pattern, and that's, as now as an AEMT, you've been through a few calls that you're like, oh, yeah, I think that's respiratory. Whereas before it was like the textbook, well, this and this, you just don't have that experience. Okay, questions, comments? We've been going for an hour, so let's just take a quick 5-minute break.
Most of this is just like review from
Yeah,
EMT and
it is. I was just thinking of it a little bit more in depth and realizing how much importance all of that has, instead of just being a robot and regurgitating.
size of BSI.
Example, signs, symptoms, allergies, medications, last order intake, events leading up to it. Did I answer the question?
Yeah.
I have a question.
Yeah.
I missed a little bit of what you were saying earlier about the quizzes and stuff.
Yeah,
Are they posted in there? Just get in the FVCC class login and start completing them?
this and everything are on the platinum. So did you create a platinum account?
Yeah, I did all the account creation. I haven't finished the last steps yet. I got your approval email. So
Okay.
if it's gonna be in there, I'll take a look at it and come
Yeah,
back
so
with
then
more
do
questions.
the assessment and then you can start working on the quizzes.
Okay. And making sure I paid attention correctly. The quizzes are open book, the platinum stuff tests are not.
The exams are
The
not.
exams. Okay. Yes. Okay.
Don't copy and paste the content from the question or anything from Platinum onto Google or try to search for it word for word, because it will recognize that as its content and it'll be in violation of their policy.
Okay.
Not to share that information outside of Platinum.
Okay.
So
And then anything on platinum?
anything on Platinum, don't cut and paste and try to put it on the web. Because
Okay.
they have abilities to be able to track that information, who put it on there, where it was posted, and then it'll suspend you from the account for 3 minutes. Then if there's a second violation, it can suspend your account for a day or 2 days. And then it can, if it's continuously violating, they can then suspend you from your account. And then they can potentially suspend us as a program from ever using it.
Okay, good to know. I was under the impression that was exam only, but yes, okay, nothing from Platinum, copy.
And if you do want to search online, hey, I'm not sure what that's talking about, I can't find it in my book, because platinum testing isn't based off of this book, it's based off of National Registry. Your book should be covering that content, so it should be there, but it's probably not gonna be, it's definitely not gonna be written there like in a quiz, word for word, that you could go back to page 27, paragraph 3, line 3, you'll see the answer. You should have a general idea, but if it's not in your book, then you can search and look for that information, just don't use the exact verbiage.
You know, patients I've had that lay on guns. I've had like
Does
sticks.
that help answer your question?
Guns.
It is the res.
It is the res, but you know. It's like-
What's that?
I was talking about how these houses are way too clean,
Oh.
for examples, like,
All levels of filth.
there's like 6 people that are just found laying on their guns, so there's just like a gun imprint on their body. Yeah. Like, oh, what type of gun is that? Oh, it's a big gun.
Lift up their shirt, find out.
Can you identify this gun?
Okay, so let's get started again. That way we can get you guys out of here. Scene size up and primary assessment. Okay, so we already talked about scene size up, primary assessment. Building the framework, of how we're gonna go through our assessments. Don't just do it in a, just get a checklist, but just think about why are we actually doing sample? What's the importance of OPQRST when we're getting that secondary assessment? Understanding the value of giving you a organized approach to prioritize what needs to be addressed first, second, third, so that we have an organized approach of addressing the most concerning potential problems that our patients facing, and then prioritizing things that are less important so that they aren't taking up time and resources trying to address sample when we really need to be focusing on airway management. Okay. Size up, discuss. So some of this is just more. Okay. Scene size up. When does it officially scene size up start?
The minute you arrive on scene in your vehicle.
Or listen to dispatch. Okay, what are some things that we can hear?
Whether we're going to an MBA.
Yeah, is this an MBA?
Seeing, are we going to a residence?
Sometimes we get information from dispatch, so when we get on scene, it's like, this is not what we thought we were going to.
Yes.
So we had a call that was childbirth. So we're thinking, where's the OB kit? Okay, I'm gonna do this. You know, scene, it was a child that had been burnt. Completely 180, so we're not doing a delivery, we don't need the OB kit. Now we need to focus on a burn patient. And where are we gonna transport? Now we're gonna take them to a burn center, not to the local hospital for baby being born. And it can be, caller is communicating to dispatch is trying to understand what they're saying, and they're doing the best they can. They may have multiple callers calling in on one particular event. But also then you should be thinking, hey, code, how is that gonna be different from difficulty breathing or knee pain? Okay, so if we get a code, what do you guys typically do on the way to that call? Hey, someone not breathing, unconscious, bystander doing something, how does that change your approach and scene size up? Yeah, hey, I'm gonna take airway, hey, I want you to be on the drug box and I want you to start CPR. Okay, so if you can start designating those roles, everybody, when they get on scene, it's not, hey, you're doing, oh, I'm gonna do, what do we do? And then you look like you're fumbling around. And so if you have those clear, so that is when I originally think of scene size up is, what are we gonna do based on what information we're gonna get? How long is it gonna take for us to get there? What are the things are we getting through our MCT that's telling us additional information that's updating us on the incident? And then what other units are gonna be responding? How are we gonna coordinate that? If you got a fire and it's a debris fire, well, are you gonna take a hydrant? Well, it depends. How big is it? Is it a junkyard that there's a debris fire or an open lot that has, some small burning, somebody's doing a warming fire? Your approach is different until you start getting on scene. Then when you get on scene, then you go the size up. And what I found is a lot of times you'll want to just go, do, especially if it's a big thing. But actually, if you just take a minute, get out of the vehicle, assess real quick, take 5 seconds, 10 seconds, it'll help you make better decisions about that first initial on-scene report and then on-scene assessment of prioritizing what do we need to do, okay? And where do we need to go? How many people do we have? Do we have the proper PPE on? Have any of you been on an MBA and forgot your vest? Because there's cars and there's people and you forgot to put your vest on. Okay, you need to have that high visibility vest to make it easier for people to hit you, right? No, I'm just kidding. But how many times does that happen though? Okay, so sometimes it's you gotta slow yourself down and you gotta slow your brain down. And if it is just a matter of take that deep breath, release that tension in your body, what it's gonna do is gonna help that prefrontal cortex of your brain, that's the decision making, making decisions, calculating risk. It's gonna help activate that rather than being in the sympathetic dominance of fight or flight, which is more reactive. And sometimes if you got on scene and you've overreacted and you're like, if I just taken 10 seconds to think about that, maybe I could have been a little bit smoother. Anybody ever done the turtle where you got your SCBA pack on, you fall down and you're on your back and you're going like this? You ever seen that? Okay. If you had taken a little bit more time stepping on or off the apparatus, as an example, okay, we've all tripped and done something silly on a scene that you got, your brain was moving faster than your body could keep up with. Okay, but that's where you get injured, that's where mistakes happen, and that can lead to a cascading event of something catastrophic. So once we've got that all in place, make sure we're taking that extra time, setting up our extrication equipment or setting up our bags, our medical equipment in a way that's organized. Looking at where the patients are, determining, hey, what is going on here? How many of you been to a small residence with lots of stuff and the patient's wedged between the toilet and the sink? And you're trying to do CPR in this tiny bathroom or this tiny bedroom and nobody else can get in, but you're in there doing CPR.
Yeah.
And how are you gonna establish airway? How are you gonna do an IV? How are you gonna defibrillate? Hey, just kinda, and then you're
Everybody's twisted together.
twisting. What if we got in there? Hey, this is not enough room for all of us to work. Pull that patient out to a bigger room or the living room. Now we all can participate, not just have one person doing CPR and hand and stuff too. Okay, so those are things we got to think about with our sizing. Okay, let's see. C-spine precautions. Can medical patients have neck injuries, spinal injuries? Absolutely. So we need to think about those things. Be aware. Checking pulse. Is it present? Is the airway open? Okay. Ways that we can open up the airway. Okay. Level of responsiveness. You know, this is all kind of stuff that we've already talked about. Getting your general impression and prioritizing sick or not so sick. And then looking around the environment also help us gather information about what could potentially be going on with our patients. So if our patient's unconscious and unresponsive, is there anything in the environment that may be contributed to that? So what could be in the environment that you could see that could make somebody unconscious and unresponsive? Smoke, gases, okay. Drug paraphernalia, alcohol bottles. I mean, you guys have been in some of these houses.
Heater, like, kerosene heater.
Yeah. Everybody's laying down in the house and no one's coming out. What should that be telling you? There may be a gas in there. And if I go walking in, I'm gonna succumb to that. So do I have my SCBA or do we need to call the fire department or have the fire department go in there with a gas meter to check? Okay, so these are all things that we're doing on a size up. And just because we do a size up, and it's safe, do we then assume it's gonna be safe the rest of the time we're there?
No.
Not at all. So we constantly have to be reassessing our size up to make sure that that change doesn't take place, that becomes unsafe. I'll give you another example. This was with Phoenix. A friend of mine that works for Phoenix and fire department. They responded to a mental health emergency. They're talking to the individual, trying to convince them, hey, we got to take you to the hospital. You know, you made some threats about wanting to harm yourself. And the guy, you know, they're going back and forth like 15 minutes talking about this. All of a sudden he gets up and starts running down the hallway. So what do? They go and follow him, right? Because and then he slams the door. So they push the door open. He had grabbed a gun out of the nightstand and then shot himself right in front of him. Bullet came very close to, you know, the other fire, because they didn't know he had a gun because the way he was reaching down and grabbing, you know, so that incident, you know, you wouldn't have thought would have turned into a suicide on scene. Not to mention the psychological, like, what just happened here? Now we got to work a trauma patient with traumatic brain injury and call for resources. Now we got a trauma patient from a mental health patient. So that's where that, sometimes even with your best intentions of making it safe, it changes so rapidly, you then now have to adapt your response to it. Okay, so let's talk about energy, kinetic energy, blunt versus penetrating. What are some of the things that we can see when it comes to kinetic energy? How does that play as far as bodily harm to somebody? Okay, bruising, okay.
Perhaps like deformation.
Oh, deformation, penetrating. Okay, what are some penetrating injuries?
Stabbings.
Okay,
Impales.
how long is the knife? How wide is it? What caliber? Is it a handgun? Is it a long gun? Is it a shotgun? All of these are going to play into how much of that kinetic energy was actually transferred to the patient, where on the patient it affected them, and then what vital organs are behind that to help us determine, is this critical or is this stable? And we've all seen some of those things. You go, how in the world are you not more injured, right? Protocols, patient assessment, purpose, airway breathing and circulation, exposure, really talked about this in depth. Okay, equipment. How many of you bring suction? Good. Depends on the call. Okay, if you got knee pain, we're gonna probably bring suction. Nah, but you never know. That knee pain could be somebody who is, do we know where it is? Is it properly charged in our vehicle? And get to that suction if we need it in a timely manner. Okay, how many of you had a dead suction unit? I have. Oh man, somebody unplugged it, or we didn't check it doing the truck check in the morning. It came unloose when it was sitting in there because you haven't used suction probably for 3 months, and nobody else checked it. So those are some of the things that we need to think about. Having our equipment, doing our equipment check before we even start our shift. I'm guilty of this. Hey, we didn't run any calls. Everything's good. And you're like, oh, well, I don't really want to go check the truck. It's kind of cold outside, or I'm gonna get some breakfast. I'm gonna get my coffee, and then all of a sudden you get a call, and then hey, where's our stethoscope? We don't have a stethoscope in our bag. How dumb do we look? Okay, so those are things we have to keep in mind too. Is make sure your equipment's up to date, that your equipment isn't failed or broken, and that it's actually in the bag and it's where it's supposed to be in the bag. Because can things get put back in the wrong pocket? Yeah. Some people add more stuff to their bag than it can actually contain, and so you're like sitting on it trying to pull that zipper around. They're like, we don't need this many trauma pads. We just need 1 or 2, right? So it's doing that effective check. Okay, making sure the batteries are working. Anybody ever showed up and your O2 bottles were not? Well, we didn't switch that out on the gurney, and now we're. I had an incident where I checked everything off, and the cover was over where the battery goes for the Zoll monitor, and I assumed the battery would be in there. You get on a call, and it's a patient that has a slow heart rate of 44 from a nursing home, And our monitor, there is no batteries. There's no batteries extra on the ride, because they always take it off. And I didn't know that, because we always kept the batteries on the ambulance. So sometimes just going from one service, if you're working for another, the practices may be different. So that was feeling that patient's pulse all the way to the hospital, because it was bradycardic, and, well, I can check a pulse, even though I don't have a monitor, but how do I explain I don't have a strip for that chart? We got lost.
Yeah.
I don't know, it fell off the back of my chart, I'm not sure, but, yeah, so things happen, okay, even to the best of us. Okay, unresponsive patients, checking for pulse. Pupils, we look at pupils, yeah, those are easy things to look at. Skin color, cyanosis, blue around the lips. We all should be familiar with doing those things. And knowing where to check a pulse. Where are the places we check for pulse? Carotid, brachial, radial, femoral, right? Okay, good. General appearance, age, and sex of the patient can play an influence in how we treat that patient. Medical conditions or medical problems that can affect age or sex of a patient can also be a factor that we look at. Are they responsive or unresponsive? Skin color, condition, pink, warm, and dry is what we want. So if it's not pink, warm, and dry, why is it not pink, warm, and dry? And level of distress. And you can tell, like, if somebody's really sick, they'll just looking in their eyes, you can tell. Hey, this person's sick. I'm not exactly sure right now what's going on, but I'm looking at that patient's giving me the look of, I am not doing well. Okay, we already talked about APU and GCS. Looking at GCS, so how do we look at GCS? We know the lowest score is 3, right? So if you say they have a GCS of 0, what is that gonna show?
You don't know what you're talking
You don't know
about.
your GCS, you're just making it up, and they must be really sick because a 0, a rock is a 3, okay? Okay, so then when we look at eyes, spontaneous, they recognize you when you come in, they're making direct eye contact. Voice, okay? They may not be acknowledging me when I come into the room or when I'm in front of them, but I can raise my voice to get their attention. Oh, yeah, you're over there, okay. Pain, what are some ways that we can measure pain? Okay, do the sternal rub, take a pen, put it on the nail, okay, that's always painful.
Rake a pen on the bottom of the foot.
Bottom of the foot, that works. Yeah, so what I like to do, this is the one, because we always have had those patients that are faking it, that we know, this person's faking it. Because you take the arm, you put it up over their head, and then magically it doesn't hit their head. You're like, you're a faker. It's the eyelash twitch. So try this. Can you close your eyes and then just barely touch the eyelashes? It's gonna twitch. Okay, you can't fake it, you can't pretend it. It's either it's gonna twitch or not gonna twitch. Especially if you're not if you're doing it to yourself, you can kind of make it a little bit because you know. But when somebody comes up there and I don't flick it like of their eye. I just brush that eyelash. I'll be able to see if it twitches. If it is, then I know they're somewhat conscious. Okay. If it doesn't flick, then that means, hey, not flick. Twitch that eyebrow, then I know that they're much more serious. Okay, no response. Oriented to person, place, time, and event. When we talk about verbal, know whether that's normal for them too. Okay, because we have people that have mental health disease or dementia, or Alzheimer's. That may be their baseline is they don't know where they're at, they don't know their name, but that's something you're going to find out from the care provider that's with them. Are they confused? Are they making sense? When I'm asking them simple questions, I should be able to answer those questions. Inappropriate words, kind of word salad. Okay. Incomprehensible sounds. Moaning. Okay. And no response at all. Obeys commands. You ask them, hey, can you squeeze your hands? Okay, which finger am I touching? They can follow their cane point to where the pain is. Okay, moves to localized pain, so they aren't. But you press on their abdomen and they move towards that. Flexors are withdrawals from pain. So we have the decordicate, where they go towards the body, like in the fetal position, or decelebrant, where they go out. Okay, flexing, withdrawing from pain, abnormal flexation or extension, that's where that, I think of, it's sometimes hard to remember decordicate, but think of core going towards, in to make a core, and then celebrate, I'm celebrating, I'm going out, okay? And then no response. So that's what we should be doing with our GCS, and having this there helps you get a more accurate GCS. Decreased responsiveness, we've talked about some of these things. Oxygen deprivation, low circulation, low glucose, opiates, alcohol, toxic exposure to a substance or gas, environmental, what would be some of the things that could cause somebody environmentally? Cold outside, that's gonna slow their response, right? If it's too hot, heat exhaustion can also influence mentally. What about temperature? They've got a fever, really high fever, or their body core temperature is really low. Infection, we all know about sepsis, being able to give a sepsis alert. That is gonna play into it because of toxins, metabolic changes, pH changes, those can all affect one's level of responsiveness. Chief complaint, okay? So when we're looking at chief complaint, make it simple. Okay, they're complaining of abdominal pain, that's their chief complaint. Okay, they may have other problems, but what makes it a higher priority? Chest pain, right? What's another one?
Difficulty breathing.
Difficulty breathing, seizures, GI bleeds,
Bad headache,
huh?
bad headache.
Really bad, splitting headache, a headache they've never felt before, or they feel a pop, or they felt, some sort of, like it's an unusual headache, not just a normal one. Immersion or submersion incidents, so they were, underwater, electrocutions, poisonings, overdoses, thinkable episodes where they just keep passing out, they don't know why. So those are things that could be more serious medical problems. Sensing airway. How do we properly assess someone's airway?
First step,
Open
see
it.
if they're able to talk to you.
Yep.
You know that it's patent, and
Right.
you're also listening if you're hearing any gurgling or wheezing.
Breathing, right?
If
What about the
they're
rate at which they're breathing?
Rate, depth.
Rate,
Rate, depth.
quality.
Breathing too fast could be a problem. Breathing too slow or shallow. Okay, so we look at the rate. What about when we're assessing pulse oximetry? That's going to give us capnography, which we'll get into more detail. That's also another great way to determine what type of respiratory waves they're making on the capnography. What should our normal range roughly be?
35 to 45.
35 to 45, but we're also going to find out there's different forms that those waveforms present. That'll also tell us, hey, they are breathing, they are within a normal range, but we're seeing these different characteristics on the capnography that's telling us there's a respiratory issue and we need to address it. Okay, let's see, proper positioning. Sometimes just positioning the neck in the right position, you can get somebody to breathe easier, okay? Okay, ever find somebody slumped over in a bed and everything, and then you just lift them up, get them to breathe a little bit, and that pulse ox will go up. So sometimes just a simple repositioning the patient is gonna help you. BVM, if we're gonna use a BVM, if we're getting resistance, what's that telling us? Okay, some sort of obstruction, could be a pneumothorax, hemopneumothorax, could be that tube is moved, okay? So we gotta think of problem solving. If we're not getting oxygenation into the body, what is it that's gonna be, that's obstructing that, preventing that from happening? Okay, risk. Let's see, decreased relaxation of the muscles or LOC, no gag reflex, risk of vomiting or aspiration. So if I have a patient that's not able to maintain their airway or is becoming more and more rapidly decreasing in their mentation, are they able to protect their airway? What's their tongue gonna do? Fall right back. Okay, so what are some things that we're gonna look for?
Snoring.
Snoring, stridor, gurgling, coughing. What can we do to stabilize that airway then?
Gel, OPA.
OPA, MPA, yep, so we can get that tongue off the back, so we can get some air down into the lungs. LOC skin is also a great indicator of telling us where somebody, the perfusion level is doing as far as breathing. Level of distress, their attention. How many of you have had somebody that's hyperventilating?
I just had one a couple days ago.
Okay.
52 respiratory rates.
Yeah. What's gonna happen though? If they don't stop and slow down their breathing?
And
Yeah, they cramp up, they get more panic, they're feeling that, oh no, and it's because that air gets trapped here in this dead space, so it can't get enough air down into the alveolar sac, can't take the CO2 that's building up, that's what's causing that anxiety feeling more, feeding that loop. And so we can't off-gas that buildup of CO2 in the lungs. If they don't slow down, eventually the body will just shut down, reset, and then they will slow down the breathing. So for those patients, rather than tell them, hey, you guys slow down your breathing, they're gonna look at you like, I can't. They're breathing too fast. So it's that, this is the simplest way is to grab that patient's hands and say, I'm gonna hold your hands, okay? And when I squeeze, I want you to hold your breath. So I'm gonna start with 1 second. Okay, and you give them that stimulus of squeezing their hands, 1 second, hold it, okay, let them breathe. Okay, now we're gonna go for 2 seconds, I'm gonna hold a little bit longer. Oh, okay. And over time, when I get to about 5 seconds, that has slowed the respiratory. Then they're gonna start feeling the tingling going away, they're gonna think you're a miracle worker. And all you're doing is you're just helping give them the physical response of squeezing and coordinating that with the respiratory rate. And then I can slow them down enough, right? Trying to put a mask on sometimes doesn't work because that just makes them even more anxious and more, and that's not doing it. It's the rate at which they're breathing is we have to slow down. So use that technique. It's worked every single time if it is truly an anxiety or panic attack. Let's see, rate, depth, rhythm. We've talked about that. When we get into airway, we'll talk about different types of breathing patterns that we can look at. Some signs of inadequate breathing. So we've talked about blueness around the lips. Ventilatory rates, we want to, less than 8 or greater than 30. We need to slow or speed up that respiratory rate. Irregular breathing and irregular breathing patterns that we're going to recognize a little bit more can also indicate head injuries or diabetic emergency, like we're gonna dive deeper into those, but it's understanding what is the norm, what's our normal respiratory rate? 12 to 20, and then it's either too fast or too slow, and we can bring it back down to that 12 to 20 rate depending on the patient or job. Okay, let's see, indications for administration of oxygen, okay? How do you guys determine whether it's going to be a nasal cannula, a non-rebreather, or BBM?
SpO2 percentage in
SpO2,
airway.
okay. What else?
Patient tolerance.
Patient tolerance, yeah. Yep, okay. So then we're also going to look at how do we maintain that oxygen saturation. We'll talk about where sometimes we don't necessarily need everybody to be at 100% when we get into the respiratory chapter. Strokes, TBI, traumatic brain injuries, where we've all been through the EPIC training, and we understand we shouldn't be delaying giving oxygen, and we should not be hyperventilating those types of patients. So we'll talk about that when we get to altered. People that are hypoxic, major trauma, person that's having shock, we want to give them that oxygen and the appropriate amount. Assessing circulation. What's some key ways of doing that? Skin color, we've already talked about where check pulses. Also feeling the pulse. If we have a strong bounding pulse versus a weak and thready pulse, being able to differentiate, not just say, yeah, they have a pulse. Well, what is that pulse telling you? That it's giving you some information about their circulatory status. Okay, let's see what else. Okay. Skin color, is it cool, pale, is it sweaty, diaphoretic? Is it pink, warm, and dry? Those are great ways of assessing that circulation too. Also, like the tongue, nail, look at the nail beds, okay? Cap
refill.
Cap refill, yeah, I don't know why I couldn't say that. Is another one. Cold temperatures can also do that. So where does that body go when it gets cold? All that blood shunts to the core. Patient care decisions. So when we're doing our seat and size up, determining if someone's sick or not so sick, and then deciding, are we gonna stay and play here for a little bit, get things stabilized, and then get them on the gurney? Or maybe we're still waiting for that transporting unit to get there, and then making the rapid decision to move quickly with a purpose, and get our patients to the transporting units to the appropriate facility. Okay, patients that have deceased. Okay, so what can we presume that somebody is, there's nothing we're gonna do. Decapitation, rigor mortis, modeling, lividity, patient's been down for unknown amount of time, but it's probably greater than, 10 minutes. Okay, are we gonna bring a dead body to the hospital? If you're not sure, start CPR, right? If they're still somewhat warm, we should, do our best to give them that best opportunity, but there's certain circumstances and, we can't go through all of them. What about DNR? Okay. If they have a DNR, make sure it's present. Make sure that we are following the guidelines. Make sure it's filled out correctly. Bring the DNR with you to the hospital. They're gonna wanna see it too. It is no different than you get on scene, hey, they have a DNR, but it's at the attorney's office. Hey, they have a DNR, but it's at the nursing home, or the nursing home, yeah, he has a DNR. Well, go get it out of his file. I need that with me, okay? Because if you're gonna follow DNR, you need to have that form when you go to the hospital to say why you did or did not do something. If it's specific as they only want BLS resuscitation versus ALS resuscitation or limited ALS resuscitation, okay? Signs of death, we talked about decomposition. Yeah. This guy is definitely deceased. Charred bodies, rigor mortis, high priority. Poor general impressions, pale, cool, diaphoretic, cardiac arrest, respiratory arrest, decreased LOC, compromised airway, unable to maintain that airway on scene, unable to control adequate breathing. Also looking at heart, do they have a slow heart rate or faster heart rate? We'll talk about cardiology later on in the chapter when you get to that. So we can differentiate stable cardiac arrhythms versus unstable ones. Any type of bleeding that is internal or external, where there's a significant amount of blood loss. Did we talk about the level of blood that we can lose roughly? You lose about 1 liter, depending on your body size. Anything more than that becomes more critical. Okay, so let's look at this lady here, okay? Let's just say she's got difficulty breathing. So on scene, what do we see? Anything that seems to, we're gonna just tabletop this through. Scene size up, anything that seems unsafe in this environment.
She could have something in her purse.
She could, okay, does she look very threatening?
Yes.
There's nothing that
Okay, looks like a librarian, right? Okay, nothing.
feels to be clearly not
How
feeling.
many patients do we have? One, right? Do we need additional resources? Not this, but does it look like she's got an airway and she's breathing? Does her skin look?
Looks normal.
Okay. All right. General appearance,
Consider cease
See,
fine, but not
obvious injuries.
necessary.
she's making eye contact. What do we give as a GCS?
Probably 15.
Probably 15, nothing's really showing up that would be indicating she's alert, she's talking to him, so not move. Looking for evidence of having a difficulty breathing. Does she have blue around her lips? Is she giving that stare that she's in distress? Is she tripod?
Not tripod.
Just kind of looking.
Yes.
Okay, then we look at ABCs, signs of difficulty breathing. Maybe your SpO2 is a little bit low, maybe they decide to give her a little bit of oxygen nasal cannula. Is that appropriate? Yeah. Check in circulation, okay, general impression, respiratory potential, level of responsiveness, she's alert, she's 8 times 4. Do we need to move with a purpose? No, probably we can talk to her a little bit, we can get sample, OPQRST, we could probably do even our secondary assessment while we're talking to her. Okay, vitals every 15 minutes. Okay, let's see, we've talked a lot about this stuff, okay. Now we're gonna move to the next one. Okay, Amanda's also put an AEMT assessment as a PDF, so if you guys wanna look at that, you guys can download it, it just gives a different, gives more of a systematic approach in doing that assessment, kind of like an AEMT. So this is just for you guys, just to look through. Scene size, it's basically everything like you would find on a national EMT. So this is just an overview of all the things that we've talked about today. Download that, that's helpful. Very assessment. We'll skip through some of this stuff that we've done. We've already talked about a lot of this stuff. Okay, history, like we talked about. Gathering that secondary assessment with additional information, patients. Vital signs, continue to monitor, history. Critical or non-critical patient. Okay, so scene size up, determine the nature of the incident, determine if the scene is safe. Patient's needs, any hazards. So this is just giving you ideas of only your general question about your problems, taking in those considerations, prioritizing. Is the patient alert? Good. Okay. Their appearance, is it good? Stable? Okay, great. Does it not appear that there's any impairment to airway, breathing, or circulation? And it's easy to just move right into that secondary assessment and start to question the patient, spend a little bit more time getting a good history of complaints or that they're experiencing today, getting those vital signs, focusing more on what is their initial complaint that we're there for, and then formulate, a plan of treatment and transportation, then reassess. So if they're continuing to stay stable in the back of our ambulance or while they're in our care, taking that second set of vitals, 15 minutes later or so, and then continuing just to reevaluate and making sure that the ventilation, their airway, breathing, circulation doesn't start to deteriorate. Okay. A critical patient. So this is where we don't want to delay that treatment. And being able to recognize those symptoms very quickly. This goes into another tablet here. Okay, so the goal is to determine what resources are needed, limiting our time on scene so that we can package that patient up, identify those immediate life threats, and then transport them without delay. Okay, and that's really kind of what it talks about. This just goes a little bit more detail, so we can go through that. We've done a lot of this. Critical trauma patients. Okay. So when we think of trauma patients, we need to think victim of injury, how did they get into the situation that they're in right now? Were they in a motor vehicle accident? Were they riding a motorcycle? Did they fall from a ladder? How high was it? So now we're taking into play that amount of energy. How was it applied to them? Where was it applied? And what significant injuries do we suspect could be underlying that are going to make this a more complicated patient, a more critical patient? Airway, breathing, circulation. Circulation can then take priority if we need to immediately stop that bleeding. Okay, reassessing that airway and maintaining that respiratory rate and trying to get that circulation up and going. So do we need to be doing CPR? Do we need to establish an IV? Do we need to, if we're in a remote area and we know that this person has lost a lot of blood, do we need to consider, can we get whole blood into the field? Because now we're using whole blood and it's available with Alert or an air medical provider for the most part here in Montana. That's how they're getting that whole blood. If we've had a significant loss of blood, let's not delay getting that blood in the field because that can make the difference between somebody being be able to stay and compensate that shock and getting into irreversible shock. That extra pint of blood can really make a difference. Okay, considering C-spine mobilization. Let's see, preparing for transport. How are we going to rapidly do our head-to-toe assessment? Stabilize that patient, put them on a backboard or seat collar, get them onto a gurney, and then minimize that time. What is the ideal and the perfect world of a critical patient? How much time should we, a maximum amount of time we should be on scene?
10 minutes.
10 minutes. Is that always practical and able to do that? No, what if they're in a car and it's going to take 30 minutes to get them out? Well, if we can have things prepped, our assessment, can have an IV established, we can be maintaining ABCs in the vehicle, and then now we've got everything set up, we've got the patient out of the vehicle, that shouldn't take us another half hour to package them up. We should then have everything ready so that we're minimizing that time of 10 minutes of once they're extricated, we can actually get them on a gurney, get them on a backboard, and then in the back of that transporter unit and then off the scene. Okay, reassessing vitals every 5 minutes, setting that monitor so it's going to record those vitals is really important because we want to see trends. Are they improving? Are they staying the same or are they deteriorating? And then intervening to stabilize that patient. Okay, we can do a lot of that stuff en route. That's possible. Okay, assessments for critical. We kind of got a lot through all of this stuff. Field impression. Questions asked the patient. I know this is just gets repetitive, so I don't want to keep going over the same thing. Assessment. Okay, we've talked a lot about this already. Documentation. Okay. How do you guys do your documentation? Okay, so what if we're just trying to get notes? Okay, some of you have the quick forms. That's a great way to just scribble down pertinent information, especially when it's a critical patient. Because if we have a critical patient, we're limited to who's on scene that can help. You don't want the clipboard medic standing there. Okay, hey, I need you to actually do stuff. We can always fill in that documentation and we can make some short notes, but let's not prioritize if we don't have the staff to somebody just sitting there scribing when we need somebody doing chest compressions, we need someone starting IVs and stuff like that, okay? And then once we get done with the incident, we can always come back, fill in the chart. We can pass off report with the notes that we have so that we're not delaying transferring that care over to somebody to a higher level provider. Doing a thorough job of our patient care reports, how important is that?
Very important.
Very important. Can we bill insurance or Medicare, Medicaid with an incomplete report?
No.
Can we bill them if we don't have a signature?
No.
So these are little details on that form that can make the difference between a free transport and care for that patient or actually getting bill and revenue that's going to help pay for our operation. Okay. We'll talk about later patient care. You guys have done patient care. in the past. So you should start being able to fill out those forms and be good at it. If you want to get better, look at people that do a really good job of documentation and learn from them. Okay, that's going to help you. Sample, we've touched on sample quite a bit already. Okay, symptoms. Okay, we've already touched on that. History, OPQRST, we've talked in depth of that. Pain. Sometimes what we do forget to ask patients is rating your pain on a scale of 1 to 10. People that live outside of the United States, sometimes that concept doesn't really make sense to them. They're not understanding 1 to 10. So there's also, with the 1 to 10, you can look at faces that are frown versus happy, and that you can point, if you have that graphic, you can point to them, where is your pain? Okay, especially if there is a language barrier, or some people just don't understand the concept. But how many of you had a patient on a scale of 1 to 10? How bad is your pain? 15. Okay, well, it's really impressive. Pain is also subjective to the individual. Some people have a higher reaction to pain. Okay, so if I look at it, I go, that can't be that painful. That's my interpretation. But what we're doing is we're trying to interpret what is the patient's perception of the pain they're experiencing, not what I think the patient should be experiencing. How many of you had that rancher, the cowboy, and they've got probably 6 broken ribs and they just want to walk it off? I ain't going to the hospital. I'm fine. They're like, but you just had a bull roll on you, okay? You need to go to the hospital. Yeah, I'm fine. I don't need nobody. Don't give me no IVs and nothing. But then you have the one person that's got the dislocated finger and is just like, the world is crumbling around them, and they're 10 out of 10, and they don't want morphine. They want Dilaudid. Like, I'm not giving you Dilaudid for a finger injury. Okay, but the cowboy who's got 4 broken ribs won't even take oxygen, right? It's all about their perception. Physical exam. Remember, we're also looking at the patient from the plane when we're describing them. Palms forward, facing forward is always the patient's right and left. Understanding the basic body systems. We've touched on that too. Palpating, inspecting, listening. Stroke scale, so be fast. So there's different assessments. Cincinnati stroke scale. So just be familiar with your organization and how you do a fast or be fast assessment, and then let the hospital know what your findings are. Don't just say, well, they're positive for be fast. Well, what specifically? So we look at balance, the eye movement, the vision, facial droop, arms drifting, speech. Okay, all of you should be familiar with how to do a stroke assessment at this point. It's just now making sure that we're documenting, we're also passing on that information. Okay, orthostatics. How many of you have done orthostatics in the field? Okay, is that a valuable way of assessing somebody's circulation? Absolutely. I am very careful when I do orthostatics, when I suspect somebody has an unsafe level of blood pressure, is if they're in a laying position, get their blood pressure, sitting them up. That's easy. If they start to get lightheaded and dizzy, well, we don't need to then do that blood pressure, right? We know just by sitting up. But it's the one where they go from sitting to standing, where they may be like, oh, okay, I'm fine. Always make sure you've got a good hold on them. And if you need 2 people to help support them, help. Because it literally, they are standing there talking to you, and they aren't going to tell you if they're going to hit the coffee table and then split their head open, which happened to me. And then you're like, I should have done a better hold on that patient. And now I've got a patient that's got a head injury, as opposed to I was checking orthostatics. So remember, an increase in pulse of 10 beats a minute or more, or a decrease in systolic pressure of 10 millimeters or more may indicate a low volume. Okay. So sometimes you don't have to do the full orthostatics to determine that, just based on how the patients present. wait 3 minutes in between those cycles, okay, roughly. We want to see that the heart is compensating and there's enough circulation or blood flow to be able to maintain that blood vessel or blood pressure. Body odor can also be something that can tell us different things. Okay, that fruity acetone smell, that fruity breath. And now you're starting to associate some of those diseases with some of those smells. Can you get off the truck and then walk into a house and smell something distinct and go, oh, that's a GI bleed now, right? Whereas before you're like, that smells bad. What is that? Now you're starting to associate that. So you know what those smells are. And now you can start determining, okay, this is probably what this is going to be, recognizing that. Decap BTLS, okay? We say most of the time, decap BTLS, arms, legs, body, chest, okay, but what does that really mean? Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. We should be looking for all of those things. So if we notice that on the body anywhere, we want to at least document it, let people know that this is what our findings are. Inspecting the eyes, palpate, use your eyes to look, listen, auscultate, knowing how to use your equipment, using it properly, taking time to make sure that you're using the proper size BP cup, just not throwing everybody on an adult that doesn't fit the adult. We should be past that by now. Sheets. Okay. All right. That's all that I had. Any questions? Anything in the chat? Okay, for anybody that's on Zoom, do you guys have any questions, comments? You want to share? I don't want to ignore you guys altogether. You guys have been pretty quiet. Anything with regards to the program or anything? Anybody have any comments or questions about?
Nope.
Okay. If you do, reach out to me or Amanda. Text me is probably the easiest way. And I can help you with anything that you're having problems with. Okay, that's all that I have. Stop sharing. And for those of you that are online, I will see you all next week. For those of you who are going to record, I want this recording later. Thank you. And if you have any questions or comments, please reach out to us.